The broadcast is now starting. All attendees are in listen-only mode.
Good morning, everyone, and welcome to our December 11th Safe and Calm webinar. This is Deanna Mitchell with Leading Age Michigan. Last week, we talked about our plan to discuss vaccines today. And in fact, we were hoping for more detailed information from the department about the distribution plans for long-term care facilities and other entities. We have been collecting questions for them and submitting them to the state. However, we haven't received any further details at this time. With the announcement this morning that from HHS that the FDA will be approving the vaccine any minute, we expect things to start moving quite quickly. And we hope to hear more of the details soon. So today's agenda then includes updates on the vaccine as we know it to date. And we also have with us this morning representatives from MICR, who will be providing an update on the Pharmacy Partnership Program. And then following that, we'll move forward with our standard agenda. So we welcome Beth Creer this morning from MICR and her team. Welcome, Beth.
Thanks, Deanna, and good morning, everyone. And, you know, before we jump in, it has obviously been an unprecedented year, and just really want to thank all of you and your teams for the commitment to patient care and our shared seniors. And, you know, 2020 obviously has been very challenging from a pandemic perspective, and just the ability and agility that you all have had to support patients is really heroic. As Deanna said, today is so exciting, and when we reflect on 2020 and all of the challenges, and from our industry perspective, really being on the front lines of the challenges, what an exciting day today is for all of us to really pivot as an industry and have the incredible opportunity to be on the front lines of recovery. So with that being said, we are greatly looking forward to partnering with all of you related to the vaccination efforts. We also know that it's a daily dynamic, that information is coming fast and furious, and our commitment to all of you is to communicate often and to keep you all apprised. And so with that being said, I'm pleased to have a few of my colleagues on the line. Ryan Jenneret, who's our Senior Director of Strategy and is basically running point for us related to our vaccination model and efforts. Brad Davis, who is my daily partner. He's also a Senior Director of Account Management, and Brad and I are both pharmacists. And in addition, supporting us on the line today and supporting, you know, our efforts on a daily basis is Matt Garlick, our sales manager, who has been in touch with many of you, as well as Connie DiFiore, who's our Director of Sales. And so, again, we greatly appreciate the opportunity today. You know, we understand that there was, you know, a choice in terms of vaccination. And just to kind of give you, before we dive into the model, we are beyond pleased to have the opportunity in the state of Michigan to be working and collaborating with 991 facilities on this vaccination effort. So with that being said, we're going to be kind of short and sweet today. We're going to review our clinic model. We're going to kind of double click into our communication strategy. We know that communication is king, and kind of what you can expect from us and when. And then in terms of everybody's time is really precious, we're going to spend a few minutes related to the resources that we have, and really kind of that one-stop shop that you all can go to get the information that you need. So with that, I'm going to turn it over to Ryan. And Blake, thank you for advancing the slide.
Yeah, thank you, Beth. And to reiterate, very excited to have the opportunity to walk everyone on the call through the CVS Health Clinic model. And we'll spend, like 5 minutes here just walking through pretty quickly what the model looks like. As you will see, we are right in the middle of a number of these steps as we walk through this. Also, for anyone who's looking for a deeper dive or a double click into information, there is a resource website that is available to everyone. The website is simply www.omnicare.com/COVID-19-vaccine-resource. We'll make sure that we communicate that out. It's in for all of the partners that have selected us. It is in their material, but highly recommend to go in there to get a better understanding. From a process standpoint, you'll see this slide, and I'd ask whoever's controlling it if they could just open it all the way up to the first 10 would be great. Really, at a very high level, it's a 10-step process. As I mentioned, the first half of the steps are already, in many instances, occurring at some level. You guys have all completed the CDC survey and either selected your pharmacy partner for the COVID vaccine clinics. In the background right now, we, CVS Health/Omnicare, have a schedule completely built out. We're really just waiting for the state of Michigan to activate their COVID-19 plans and tell us if there's any additional prioritization. And then we will begin communicating out the schedule to all of the partners that selected CVS Health. As soon as that schedule is available and we begin scheduling, there will be email notifications going out. You will receive 2 separate emails, one for each of the first 2 clinics with date and some other important information on it. As many of you are aware, that you've had a number of opportunities to share updated contact information either through some portal access or through some direct outreach that's occurring or is currently occurring. So if you haven't been contacted yet by somebody from CVS Health, that outreach is occurring as we speak. Those email notifications will go to anyone that has been identified as a primary or secondary contact. In the very near future, you'll receive a package of information from us. In that packet of information is a number of things, but the 2 most important are consent forms, a triplicate version of a consent form. Again, a draft or a copy of that is available on the resource landing page that I mentioned before. And shortly after receiving those emails, at step 5, you'll receive confirmation calls. A phone call will come from 1-800-SHOP-CVS, confirming the dates on your clinics, asking you for really a second assumption around the total number of volume you expect to be vaccinated, both patients and staff. And that outreach is a great forum to answer any questions. The resources that are reaching out are knowledgeable and informed on the process. So if you have questions that you haven't been able to get answered yet, that's a great opportunity to do so. Basically, as you hang up from that phone call, within the next handful of hours, you will be receiving a confirmation call, a confirmation email. That is something that's very important that will ask you to put away somewhere safe in your email folders. That email confirms the dates, but it also will provide you a direct link for Access Portal for you to upload information, which we'll talk about in step 8. Following those confirmation emails, again, we would ask you to be working on completing the consent forms and getting copies of insurance cards for each participant that is going to take part in our vaccine clinics. We are also asking that you complete and upload through that link in that confirmation email a multi-patient registration form. It's really, it looks like an Excel document that can be populated with information that is available on the consent forms. What this is going to do is help us with reporting to both the state and federal registries around who is being vaccinated, what vaccine was utilized, etc. But also importantly, it will help us understand, kind of the flow of how you would like the vaccinations to take place in your buildings. Once that is uploaded into the portal that is available through that confirmation email, We will come on site in the date of the clinics and bring all of the supplies that are required, PPE, syringes, obviously the vaccine, and a number, depending on the volume of staff or patients that are going to be vaccinated. Obviously the pharmacy team size or the vaccination team size will fluctuate. There is a number of additional communications that will come, again, and resources to help everyone prepare for these clinics. On the skilled nursing side of the vaccine clinics, we will do a much more room-to-room model, and we will be asking for some assistance. Again, that is outlined on that resource landing page, what that assistance is, and going door to door. And in our senior living or assisted living type settings, we will be doing a more centralized clinic model, much like our very successful flu clinic models that we do today. And then post the clinic, the first clinic, we will provide all of the documentation that is required to the facilities, to the patients, and as I mentioned prior, to the state and federal registries as per the standards outset in the MOU with Operation Warp Speed, HHS, etc. That process, obviously outside of steps 1 and 2 and 3, really will continue throughout your 2 or 3 clinics that you require to ensure vaccination of all potential patients, residents, and or staff. Again, I know I went through that pretty quick. There's a lot of detail within each one of those steps. Again, I can't recommend enough for everyone to visit the landing page and look through the resource library. There's a ton of information and education as well as checklists and whatnot to help you get prepared for us to come on and provide those vaccine clinics. With that, I'll pass it back over to you.
So Blake, we can advance, and Brad will talk about key communication.
Hello, good morning. My name is Brad Davis. As Beth said, I'm a senior director inside of OmniCare. I work alongside Beth. I am a pharmacist myself, and before I get into this, I would like to take the opportunity to once again appreciate and thank everyone for their continued and utmost care to their patients and residents. As a pharmacist married to a nurse, I can say it isn't just that everyone has risen to the occasion, but the length of time that this has been going on and the continued level of patient care is truly inspiring as we look at what's being done on the front lines. And I would just say it's a very, very awesome privilege and an enormous responsibility that we take very seriously to help partner with you in treating these that are most vulnerable and getting them what they need. So with that said, I would like to outline a little bit of what you can expect and some of the things that already have happened from a communication standpoint. Emails have gone out, phone calls have been made to each of the buildings that have signed up through OmniCare CVS Health, in which we've walked through the materials that are out there at a high level. Once that is filled out and questions are answered, there'll be another automated email from the scheduler providing those clinic dates. But even before then, I do want to make a point that it's very, very important that the contact person inside each facility is very clearly identified with that information, because that is where the information is going to, either via email or when we make a phone call, that is who we're asking for. So it really is important that we have the correct contact information and person inside each facility. Once the information gets there, they'll have an idea of when the clinic date is. Again, as we approach that date, there will be a confirmation call from the pharmacy team confirming all the details, confirming the date so that, again, there's no surprises and that everyone is aware. Once that phone call is made, another email will come out, again, with confirmation of the first date and then probably the second date. And then, of course, 1 week prior, there'll be another phone call We firmly believe we cannot over-communicate this. We do want everyone to be prepared so that we can vaccinate as many individuals that consent as possible. But again, there will be some emails, some phone calls. I think the utmost important thing is that we have the correct and accurate contact person with that information inside of each building. Is that whom we will be reaching out to. You can also see at the bottom of this slide, Ryan had mentioned the key resources. That is the website that's available to everyone. So please feel free to go to that website. There are FAQs and there are a lot of good information that's there today. You can advance to the next slide. Thank you. So again, next steps, right? Verify and submit facility point of contact. Most of that has been done. So we do have that. Again, it's very important. With that resource information, your teams can access that, make themselves familiar with the process, know what to expect. We'll also have our account managers reaching out to the facilities to answer questions to help prepare. So we'll be there as a resource in addition to that. I would advise to download that client guide. Anything that can be filled out or anything that can be reviewed prior to leads to better questions and, of course, better preparation, so that day of we are all in sync and can handle this with minimal disruption to your staff and residents. And then as we get new information, as things change or evolve, or as we begin to confirm, we will, it is built into our protocol, we will be reaching out via email, via phone call, and always via that website. So feel free to keep that website and reference it as much as possible, as the information will always be posted there as well. So with that, I'm going to flip it back to Beth. Again, I cannot thank the people on the front lines, the nurses, everyone on the front line who has really done a remarkable job through this pandemic. Beth?
Thanks, Brad. And, I would just say that, one of the things we probably have heard multiple times throughout just this 15-minute discussion, and we've repeated it purposefully, is if there's one nugget in terms of knowledge to take away, is really looking at this web page. We are doing our best to bucketize information in terms of a one-stop shop, because everything is so dynamic in nature that we're really focused on providing a robust website that can provide all the information you need in one spot. So that's the one nugget of kind of knowledge to take with all of you today, is to please, bookmark this website where we are doing our best to bucketize information and keep you informed as everything is changing. In addition, I would just say that, we started the call talking about, the outreach and how communication is going to be purposeful and often. And so, as Brad said, you should have heard, and we know Matt is making a lot of phone calls as well, you should have heard from us. And so, in addition to bookmarking this webpage, mark your calendar for Tuesday of next week. If you have not heard from us by Tuesday of next week in terms of somebody outreaching, and you are receiving your vaccine from CVS Health, you can see at the bottom of this slide is a link to where it says questions. And so the ask is, if you have not heard from anybody on Tuesday and you are getting your vaccine from us, to click on that link at the bottom, and in the subject line, put contact. And then your information in terms of name and address and contact information, and we will reach out. So with that, again, we want to thank everyone again for what you do on a daily basis. It is our privilege and pleasure to partner with many of you on the vaccination efforts. And I'm sure, one day when we all kind of reflect on our careers, that being on, the front lines of the recovery efforts is really going to be a proud moment. So thank you for the time, and Deanna, and I will turn it back to you.
All right.
Thank you, Beth. Go ahead, Blake.
All right, thank you very much. And everyone who just joined us from Omnicare, we do have a couple questions, so I just want to jump into those really quick. Obtaining actual insurance cards from residents is a major concern. Majority of LTC AL residents do not have physical insurance cards. We load their insurance info into our EMRs at move-in, and that is how we access it.
Yeah, Beth, I think I'll take that. I think it's a great question. So we've heard, from a number of long-term care facilities across the country, a very similar. I think we are on the precipice of getting something else approved that would be much easier to obtain around admission information that really contains a lot of what we need for the insurance, the reason why we're asking for copies of it. So again, I nothing 100% concrete today, but I think within the next 24 hours, we will have an update to that policy that we will happily share with everyone.
Okay, thank you for that. How will we provide vaccines for residents, team members who move in or are hired after the 3 vaccine clinics?
Yeah, so this is Ryan Generette again. I'll take that one. So the ask from this prioritization or phase 1, if you will, is obviously a unique ask. And when you think about the way that the scheduling of these 3 clinics will be, it's approximately 90 to 120 days, let's call it. There is belief that based on the vaccine quantities that will become available, that we will move to a model that is much more similar to how we currently service or people procure medications or vaccines in the normal day-to-day, meaning that there's an expectation that your current provider would be able to support your vaccination requests in, again, a normal process if that vaccine is much more available.
This is Deanna from Leading Age. I would like to jump in here just a moment. The department is recommending that for residents that might be coming from the hospital, that the facility work with the hospital to ensure that those residents, those patients are vaccinated before discharge. And also the possibility for residents who might be moving into your community from the local area become vaccinated before they come in. That's what MDHHS is recommending at this point.
Yes. And Indiana, obviously we know, with the different vaccines and having, the 2-step that, coordination and collaboration is going to be key. I would kind of just add that it's very purposeful, out of the gate of having these 3 clinics. And, for those of you that deal with us on the flu side, typically there's an ability to collaborate on dates. However, with that fluidity of the vaccines and the timeline, this is why, we are really pushing out the dates of the clinic to make sure that we're hitting those marks in terms of the administration piece. But to your point, even with, people being discharged and coming in, there's going to be, a lot of coordination and collaboration based on the timeline as well as that 2-step.
Okay, thank you for that. Paper consents are going to be very challenging to obtain on residents who have POAs who may live out of state or not be readily available. Can we get an electronic option for consent?
And Ryan, I'll start, or are you still out there? And then you can jump in. I know we are exploring an electronic option. The keyword is exploring. We are not there yet. However, in terms of the consent forms that we have today, Ryan, maybe if you want to talk about, I believe there's an opportunity for the verbal consent is same kind of that there is on the flu side, but we are exploring electronic options. But at this point in time, it is that triplicate form.
Yeah, Beth, I think that's well said. And much like my comment earlier on insurance information, I think, CVS Health has heard the concerns from the long-term care community around the challenges within this. And as you mentioned, Beth, we are going to be pivoting to, I think, a more conducive process. In some instances, as you mentioned, the potential for an electronic or editable PDF that would be available to be printed out. Also, the opportunity to do some things around POA and alternative signatures that would, in some elements, take responsibility away from having to get wet signatures on the paper forms, as they mentioned, which would be a challenge.
Okay. Give me 1 second here. Would it be possible to just have Omnicare charge the facility for administration instead of asking for employees' insurance cards?
Yeah, so I think there's a possibility there, and I would work closely with the outreach owner that is completing the outreach to you. Just to clarify, if a person has insurance or doesn't, there's no out-of-pocket cost to the vaccine recipients. So if they don't have insurance and therefore couldn't produce an insurance card, they still will be vaccinated. They will be supported by the HRSA funding that is available through the government. And so I think I'd answer that kind of that two ways.
Okay.
Yes.
Oh, I'm sorry. You can go ahead.
Yes, that, Ryan hit it spot on, communicate directly to the outreach person. However, if there is insurance, having that is important information for us. But as Ryan alluded to, that's not a barrier to vaccine administration. I think those are the three highlights. And Ryan, I don't know if there's anything else, but I think those are the three key components.
Oh, Beth, I think that's it.
Okay. What about those of us who may have chosen another pharmacy to coordinate with? Will they be getting with us? And has anyone heard from other pharmacies? I don't know.
This is Anna. Yeah. We have tried to contact Walgreens, but we haven't found the appropriate contact person yet. But we are working with both the department and Leading Age National to find a contact person to coordinate that. I do know that there were a couple questions out there about the Walgreens plan, and we are working to try and get you some information about that.
Thank you, Deanna. Would we also work with our local pharmacy for new staff members?
I don't know if Omnicare has a plan for that or not, but that's one of the pieces that isn't really clear. And even though the department is suggesting that new residents, patients coming from the hospital be vaccinated, it's a vaccination process. So if they haven't started that process before they come to your facility, they're going to have to finish it there. So there are a lot of logistical issues that we're still not sure about once you get beyond the pharmacy partnership program. And we are working with the department to figure out those answers.
Okay. Getting the consent forms completed up front is going to be time intensive. When can we anticipate getting the triplicate copies of the vaccine?
Yeah, so again, Ryan speaking, the consent forms as part of our vaccine package will be sent out. We are still, as mentioned before, waiting for the state of Michigan to activate their plan. With that being said, we would anticipate that shipping process and the recipients to start receiving them probably within the next handful of days, 5 to 7 days, realistically based on what timing we anticipate that we are going to be requested to start clinics.
Okay, thank you very much. So right now, it actually looks like that was the last question. So we would like to thank everyone on the OmniCare team who joined us today. Thank you very much for coming in and giving a great presentation and answering some of our members' questions. It looks like we can go ahead and move forward now.
Thanks, Blake and Deanna.
Thank you. So we're now going to turn to Dalton, who is going to give us a very brief advocacy update before we move on to resources and guidance.
Good morning, everyone, and thank you for taking the time to be on our call today. As you may have heard, this week in the legislature got a little weird. I will say this lame duck has been a very unique process, even different than the last one, which in itself was unique. As you may have heard, a number of House of Representatives members tested positive for COVID-19, and because of that, they decided to cancel all House sessions and committees for the week. So in the past week, we haven't seen a ton of action move on a number of topics we've been watching. What does this mean to us as Michiganders and as a association? It means that the legislature has 3 session days left to pass any bills that they wish to pass with the House's consent. The Senate was still active during this time, but they weren't incredibly active like we have seen in the prior weeks and what we expected. So this next week, we do expect to be pretty active. They have 3 session days left, as I said, and I have heard that they're planning to schedule another session day sometime the week before Christmas, but that session day will have 2 or 3 larger items that they want to get done, and they're hoping to have all the other information taken care of before then. So these next 2 to 3 days will be when we're going to see things moving. As for bills we've been talking about, I know I've talked a lot about the electronic monitoring bill in the past 2 webinars. Right now, where it stands, we believe that that bill's likely going to move out of that committee, but we do know that the other House committees haven't really been looking at what's going to be coming to their committee and instead been focusing what's on their agenda right now, what do I need to get done for this next week. So not a lot of information is known out there beyond the immediate. We will continue to watch this, obviously, as it goes through. We've been watching it closely and very involved in the process the entire time. But other than that, that's kind of what's been going on at the legislative level and kind of where we stand going forward. And once again, I just wanted to highlight the 15th as the CRC and CR or CRF application deadline. And you can see the other dates here.
Okay, thank you, Dalton. We're running a little bit behind time, so I'm going to run through the data very quickly. We'll start with our routine graph displaying the caseload, and you can see that we're plateauing, which is a good sign, especially considering we are just beyond the contagious period following Thanksgiving. So that in essence is looking very good. In terms of deaths, however, you can see that the Michigan 7-day rolling average is increasing and increased sharply yesterday. But if caseload continues to go down, we hope to see this go down very quickly soon. Looking at the CMS positivity rates, we had like 8 more counties in the red area this week compared to last week. Mostly they moved up from the yellow, so that although we're doing better, we still have increased CMS positivity. But remember that there's a lag period here, so this data is only as of 12/7. I've not updated this graph today. We had some problems accessing the website, so we can just pass through that slide. In terms of nursing home cases, we did see another slight increase in caseload over the past week, but you can see the rate of incline is much slower. For HFAs, again, another slight decline, which is a good sign. Fairly slow. Pretty much holding steady. Last week they had 162 new cases. For AFCs, however, there's been a sharp incline in the past week, and it has been inclining pretty much since more facilities started reporting in late November. So with 76% reporting, which is just a tad more than last week, we did see another sharp incline, so it seems like there's a lot of outbreaks in our AFCs. This table I'm not going to spend a lot of time on, but it shows the cumulative numbers. It shows the staff and the resident case numbers and how they've moved over the last week. So pretty much nursing homes are considered a point of concern, and the AARP just put out a report for Michigan that identifies that. We've yet to review that in detail, but we do know that there are a considerable number of outbreaks in nursing homes and other long-term care facilities as we move forward. So moving on to resources and guidance, we're going to be focusing a little bit more on vaccines in general. We're going to go over the visitation update and the FAQs that have been issued for COVID relief facilities. So very general information about the COVID vaccines. We're still waiting for more logistical details to come from MDHHS. Overall, HHS anticipates being able to immunize about 100 million persons by March. That's about 25% of the total population in the U.S. And they do believe that they'll be able to distribute the vaccine within 24 hours of the actual authorization. We did hear from HHS this morning that the FDA plans to approve finally the authorization today, but when we started the webinar, they had not yet formally done that. We did talk last week about the recommendations that health professionals encourage patients to receive the vaccine, and the CDC has developed a tool for healthcare professionals to help in those conversations. And they put together some responses to some common questions, and both those links are noted here. One of the things that I thought was interesting, and I'm sure that some of you may be aware of, but perhaps not all, is that these vaccines have been developed using what is called messenger RNA technology, or mRNA. The concepts behind this type of vaccine development have actually been studied for the past 10 years. But these are the very first vaccines to be developed successfully using those methods. Apparently, the problem has been with stability, keeping the vaccine stable and usable over time. And that is why they have to be stored carefully. And one of them has to be ultra cold storage is required for that. So unlike the current vaccines, they don't contain any viral elements, either live or deactivated. And messenger RNA in general is an essential element that's used in how cells make proteins. And they do that by transmitting codes, genetic codes, to make those proteins to certain parts of the cells. So scientists have created these strands of mRNA in the laboratory that will tell the body to make proteins that have spikes that will look like the virus. And the response of the body will be to create an immune response to that, to anything that kind of looks like the coronavirus. So this is important new technology and apparently very, very positive and optimistic approach as per the scientific community. They're very excited about this. Right now the Pfizer vaccine has been pretty much approved, and clinical trials have shown it to be 90% effective, which is a very high rate. And the Moderna vaccine is expected to be approved shortly as well, and has a 94% effectiveness rate. So considering that there's no infectious element in the vaccine and that it makes the manufacturing time shorter, there's a lot of optimism, again, about this kind of technology. The FDA has developed several informational web pages for further information, and they're noted here. We do know that the recent CDC recommendations have included healthcare personnel along with residents in long-term care facilities as the priority population for vaccine administration, at least where to start. And we repeat that although MDHHS is actually in charge of how the vaccine will be distributed across the state, they pretty much have determined that same basic distribution plan. What is not clear is how staff and residents in different types of long-term care communities will be prioritized. But we do have a clear sense that they will start with hospital health professionals and residents in nursing homes. The CDC also has several avenues to monitor the response to vaccinations and has several tools to track this on an ongoing basis. One is called Be Safe, and this is a smartphone-based app for follow-up. You can report any untoward symptoms directly to the CDC via the phone. In addition, NHSN will report vaccine outcomes to the CDC Vaccine Adverse Reporting System, and the FDA also reviews claims for vaccine administration in terms of any following conditions that might occur following a claim for vaccine administration. So that's the way they monitor untoward effects as well. So there are also websites that speak to these plans for monitoring, and two are on the slide here. Here in Michigan, MDHHS uses MICR to track and monitor the use of vaccines. We do know that they put out a notice that providers have to be registered in MICR in order to administer the vaccine. But they also then later provided an update about vaccine distribution, which identified at least some of their plans. So we all know that those enrolled in the Pharmacy Partnership Program will be scheduling 3 clinics. They will have 3 scheduled clinics in each facility. And after that, the department says that each facility must decide whether to continue to work with that pharmacy after the initial program, or they will need to contact their own pharmacy or local health department for any later needs. They've also clarified that they recommend that facilities not register in MICR because they don't see the facilities themselves administering any doses here. That website in MICR is used to also distribute the vaccines, considering the storage issues and how the doses are going to be distributed. They don't believe at this point, at least, that facilities will or should be administering their own vaccines. The storage issues are considerable. However, we haven't gotten final guidance, but this was this is what we received from the department last week. There, again, as I said earlier, there's also a suggestion to work with local hospitals to ensure that their discharges are vaccinated before admission to any post-acute or long-term care, and to consider any admissions from the community to be vaccinated on their own before admission. But again, remember, this is a two-step process, so there are some logistical issues around this, and we're still working with the department to figure those out. Facilities who are not participating in the pharmacy partnership program are going to have to work with local health departments to obtain vaccines, vaccination, and some can partner with hospitals. That's pretty much what we've heard from the state to date about all of that. The department has issued a lot of guidance about their vaccination plan, although much of their plans were written in October and they don't really talk about the logistical issues that we're seeking more information about. They haven't really been updated either. So, and some of this information is listed for providers of the vaccine, and it's available in case you want to review. But we know that most facilities will likely not be doing that. So this is just for your information if you have an interest. A few other notes from the department about vaccine distribution. Information sheets about the vaccine are going to be distributed at the time it's administered, and each person will also receive a vaccination card that will include a second dose date. Information about how to use that Be Safe application that allows individuals to report any untoward effects will also be provided. I'm not sure if that's really pertinent for the long-term care consumers, but for the general public at least. And providers must report adverse events and any errors in the CDC adverse reporting system. And that would be for people using the pharmacy programs. They will have to do that. So moving on, Blake. So the last department distribution plan was written in the October 25th document. That's their planning document. It hasn't been updated again since that time. That states pretty much that the initial allocations are going to go to the 143 hospitals and health systems in Michigan, primarily for their healthcare workers. And then distribution will fall to local health departments beyond that. The pharmacy partnership program will take care of long-term care facilities. And again, we have about 10 to 12 questions out to the department waiting for response. About 2 weeks ago, Dr. Caldoun did offer this list during one of the governor's press conferences in terms of their priority system. And the goal ultimately is always, number one, to keep the health systems working, and their priority is ICU workers, hospital medical floor workers, EMS workers, ER staff, and then following that, care facility workers and residents of skilled nursing facilities. And again, we don't know how that works out in terms of all of the long-term care settings. Eventually, it will expand to other healthcare workers and essential workers and those at high risk, and then to the general public. So we can take a few questions now, but we do want to note that there's an awful lot of logistical questions that we don't have the answers to yet.
All right, thank you very much, Deanna. Before we get into any questions, Leading Age Michigan wants to thank our business partners for their continued support during the pandemic, and we encourage you to take a look at the logos on the screen. These are the organizations that continue to support the association and your organizations as well. Without their continued support, the Education Foundation would be unable to be as dynamic and innovative as we are. Therefore, when you are considering a purchase of goods or services, please remember this page of logos and consider making a purchase from one of these fine organizations. As of right now, we do not have any questions, so we can keep moving forward.
Okay, great. So for our housing members, just to note that HUD has released a disaster preparedness continuity toolkit, and we'll be discussing it during a webinar later today. For those who are interested, the site for registration is on the slide. And moving forward, but yes, thank you. And the FDA has approved a Quest diagnostic test that will test for both influenza A and B and COVID as well. It's designed more for home testing, but we anticipate that there are going to be a lot more products coming out that will test for all of these viruses at the same time. This is just for your information at this point. And then, as we all know, the department updated the residential visitation guidance earlier this week. And most of the changes were welcome. They seem to respond to a lot of the issues, but not all. But a lot of the issues that we have been concerned about and have been talking with them about over the past many weeks. We also identified a few confusing areas, and we're still waiting for the department to respond to questions about that. So this was issued on the 8th, and it does rescind the October 21 guidance. I have, as usual, included a review of the entire guidance here, although only mostly the visitation parts appear to have been changed. So we'll go through this fairly quickly, the portions that haven't changed, but we will spend most of our time, obviously, on visitation. So all the same notification and reporting rules are still in place. Those have not changed. So we can move on to the next slide. This slide identifies a bit more of the reporting requirements, but again, those haven't changed. But it does include a few new statements about independent living. And although independent living is no longer included in any of the visitation restrictions, the department wants to emphasize that they must contact their local health department when they become aware of any COVID positive employee or resident. And they must work with the local health department in any contact tracing efforts when asked. So a lot of the visitation guidance from October 21 again remained the same, but there were some slight changes that made the rules a bit more flexible for patients, residents, and facilities. Again, this is for nursing homes, home for the aged, adult foster care, and assisted living. And this is a list of what they must do in order to allow any visitation, whether indoor or out. And there are, of course, some exceptions to some of these rules, which we will go through in a bit. But in general, in order to do visitation, unless you're in one of the exception categories, facilities must not be an outbreak response status. The county risk level must be low, A, B, C, or D. A new change is that they are now allowing outdoor visits in level E, but with the weather changing, that might be a bit hard for people. But they are allowing outdoor visits in all risk levels now. And again, the local health department must not have issued a prohibition on visits at your facility. And of course, there are testing requirements for certain visitors. Additionally, the general rules for visits have not changed. They must be by appointment. They must be timed, logged in, logged out. Visitors must provide contact information and a test to notify the facility if there are any symptoms. Pretty much none of the rest of these issues have changed. All of the basic requirements for visitation are being upheld here. There is a reminder in the list of all of the requirements that you must make available an employee or a volunteer trained in infection control at all times during visitation. But they do not have to supervise each visit. That was from a much earlier guidance. Note that there should be no food sharing. I think that is something that's gotten a little lost in the process here. And you're also required to ensure that residents and families are updated about the visitation requirements on an ongoing basis. So as they change, you have to communicate with residents and families. And last, this is the long list that pretty much hasn't changed about what the rules are for all visitation. If you notice at the end of the slide, there are still absolutely no visits allowed for persons who are COVID positive or under observation. We continue to advocate for a change here, but the department recently came down very hard on this again this past week, and it continues to be very messy with a lot of pressures from all sorts of different sources around us pushing for end-of-life visitation, understandably, for COVID positive persons and persons under observation. Another issue with this is that CMS, through their visitation guidance in QSO 2039, states that end-of-life visits can be made for COVID positive persons. And the long-term care ombudsman in Michigan is fighting hard for these visits as well. But MDHHS is adamant that they should not occur. So we're continuing to have discussions as we go forward. We found this next section to be a bit confusing, and we have a question out to the department about this and have not yet received a response. The question is about ADL visits. ADL visits can include physical contact, and there is a requirement that they can only have that contact for 15 minutes during the visit, which we all know that that's not really long enough to feed someone effectively. So the narrative, the actual guidance itself, continues to note that time limit, but the infographic doesn't say that. The infographic says that there are no limitations in terms of physical contact. So we're unclear about what the department's intention was here. We do note that end-of-life visits do have a 15-minute limit on contact. Outdoor visitation rules have not changed. There's pretty much nothing new here. So these are the exceptions to the visitation restrictions. In other words, they can occur whether or not you have an outbreak, whether or not your county risk level is E or not. In other words, no matter what your county risk level is. And even if the local health department prohibits visitation. So the issues on this slide, the categories on this slide rather, are those things that are always allowed. Window visits are always okay. Note that window visits for the department means that there must be a sealed barrier between the resident and the visitor. We do know that some facilities have added a shelter to the outside of the building that allows window visits with some protection for the visitor, and those are okay as long as there is no communication in terms of air. There's a seal between the resident and the visitor. ADL visits are always allowed except again for COVID positive persons or persons in observation. And if there is another reason for disapproving these visits, you must provide a statement to that effect to the consumer and their family and your rationale, and a copy must go to the department and the ombudsman. Visits for persons in serious condition or hospice care, pretty much the same thing. If you denied a visit outside of either the visitor or the resident being COVID positive, you have to provide a notice and a rationale. Medical service providers can come into your facility regardless of all of the other risk issues. And that category now includes resident physicians and clinical students. So that's a piece that's new. And although there is a reference in the document to section 2E6, 2E6 does not actually appear in the document. We think that's an error. We believe that that was supposed to be end-of-life visits, which we know are always allowed, whether there's an outbreak or a high county risk level as well. Non-medical service providers, and this part is new as well, can now be allowed in the facility when the county level is E. And volunteers are also permitted in the facility in county risk level E. But these two categories are not allowed for visits if there is an outbreak or if the local health department prohibits visitation. So it's simply the county risk level that has changed for these groups of providers. The testing guidance is pretty much unchanged, still not required for window or end-of-life visits. And of course, you have to test medical providers, non-medical providers, medical residents, and students using the same schedule as for other staff. They continue to encourage point-of-care testing for that. So that pretty much includes all of the updates to visitation. And we figured out that if you really want the guidance to change, all you really have to do is make a complicated table. And as soon as you do, you'll have to update it, which we have done here. We, of course, are not going to go through this, but we've updated our summary table here, which you might find helpful. We are going to, it requires a little bit of formatting yet to go into a Word document, and we'll be sending it out and putting it on our website shortly, hopefully today. Pretty much our last topic is about the FAQs that MDHHS, excuse me, that was way back when, MDHHS put out for COVID relief facilities. They still encourage providers who may not meet the criteria to apply. They can tell from the application what portion you are not able to meet the criteria for. So they still want you to apply if you want to become a COVID relief facility and fill out the application to the point you can. The link for the FAQs that isn't the link, so my apologies. That's how to contact them. So I thought it was there, but there is it is out in the policy bulletins for MSA. We can get that to you if you want. I thought that I put the link in there, but apparently I didn't. So there's some important changes here. The FAQ defines what dedicated staff are. It talks about the idea of restricting other ancillary personnel. So when it speaks to dedicated staff, it almost seems like they did see possibilities where some staff could enter the unit if absolutely necessary, such as dietary staff. But the department, and in particular the CDC, suggests that you have your direct care staff take on some of those roles as much as you can, and you keep anyone moving in and out of that area who aren't dedicated to it and staying in it to an absolute minimum. But one of the important pieces that they said that I think is going to be helpful to a lot of our members is that if you cannot keep a fully dedicated staff, they are going to allow staff that you can dedicate for one shift at a minimum. They really emphasize the need for fully dedicated staff over time, but they will allow it if you can make sure that staff members are not moving anywhere else except that facility, that unit for one shift. You can use those persons when needed. So that's going to create more flexibilities for members who want to become a COVID relief facility. Additionally, they provide some additional information about designated areas. They specifically want to know how the facility will convert to space. Members need to include in their application any transition plans for current non-COVID residents. They want to identify specifically which rooms will be used, not just for the patients and the residents, but specifically for the staff, where you're going to put barriers, how you're going to have a donning and doffing area, where are the staff support rooms going to be, and also how to prevent cross-contamination in any common areas. Another thing that they stated is that if you plan to admit new residents, the unit must be up and in place by the time of the application. If you're retaining only, you can simply be in process. And Laura, of course, will be reviewing some facilities, mostly virtual, I think, but for the facilities that are planning to admit new residents, I believe that some of those at least have been on site. So that was a lot of information today. Let's see if we have any final questions.
All right, thank you very much, Deanna. Excuse me there. Well, actually, we have a decent list here, so I will just go ahead and hop into the questions. Someone said that they are unable to print the handouts this time. If you're ever having issues with the handouts, I'm just going to throw this over here. You can always go to our Leading Age Michigan website. As soon as you hop on our homepage here, you're going to see this banner. You can go ahead and click on that, and you're going to want to scroll down until you see Leading Age Michigan COVID-19 Wednesdays and Fridays webinar, previous webinars, and then this has the date and recording, the link to the PowerPoint of every webinar that we have done in this series so far. Today is December 11th, so I do already have the PowerPoint up, and then by the time that probably this afternoon, we'll have the recording up if you want to watch that, and that link will be there. So just wanted to give you that reminder. So can you clarify if testing is required for outdoor visits now that we can have our outdoor visits in E?
Can you go back to the table, please, Blake? I believe that they're not, that testing is not required for outdoor visits. Testing required, no. Says none right there. I think I did question that myself when I went back and looked at it, but I could not find anywhere that said the testing was required for outdoor visits alone. And in fact, the section on testing says for indoor visitation.
Will we need to test any surveyors prior to allowing entry into the building?
We are anticipating that you are going to be testing surveyors in the future. If you go back to the table, I think I'm going to need that again, Blake. Sorry. We anticipate that that's coming. There's been a lot of discussion about it. I believe that that guidance is coming actually anytime. Michigan is one of the few states we have pushed hard for surveyor testing, and there are a lot of rules about this. I apologize, I have to take that back. I think that that guidance is already out there. I'll have to refresh my brain about that. But yes, the primary mechanism for surveyor testing is the facility. And there are some other options that can be used, but if you're having a surveyor and you're using doing point of care testing, the expectation is that you do that testing. And forgive me, my brain went awry there for a minute.
Regarding CR facility guidance to retain and to admit with a COVID positive, it says CRC must be more than 25 miles away. Who should the CRC be more than 25 miles away from, the nursing home or the potential resident's address?
My assumption when I first read that guidance was that we're talking about the facility. We can see clarification about that, but I do believe it's the facility that they're talking about.
Regarding CR facility with which can now retain and admit COVID positive residents to a dedicated unit, can we cohort COVID positive residents in the same room?
My understanding is that you could always have done that. I don't see any reason not to. I don't see any guidance that says you can't. I believe that there's CDC guidance that says you can. I think the preference is a single room, but you can cohort those residents together if needed.
If you have a resident who resides in HFA and needs to be admitted to the on-campus health center for care, is this counted as a new admission into the CRF?
No, not as long as that they're on campus. They have to be on your campus, though. It can't be a facility that's not on your campus. Part of the department's reasoning for allowing that is that they believe that even though these are separate entities, that there's some sharing of, that they're all part of the same community. But if they're on a different campus that you might have, no, that would be a new admission.
Are window visits not permitted for COVID positive residents?
No. COVID positive residents, well, let me reframe that. COVID positive residents are not really intended to leave their room ever. So if you can have a window visit for a COVID positive resident where they don't leave their room, I would say yes. I don't think that this has been tested and is stated anywhere in guidance, but I think that there's enough information around it to know that, number one, COVID positive persons should not be leaving their rooms for window visits. But if you can manage a window visit without the person leaving the room, I think that there's no guidance that says you cannot or should not do that.
All right, as of now, that looks like that was our last question. So as always, if you do think of something after the webinar has concluded, you can always fire an email off to Dalton Deanna or safeandcalm@leadingagemi.org, and we will make sure to get that question answered for you. So at this time, we would like to thank Dalton and Deanna, and we would also like to thank everyone from the OmniCare CVS team who joined us today. And we would also now like to thank our members and participants. I believe we had 100 participants that took time out of their busy schedules to join us for today's webinar. We appreciate everything you guys do each and every day to support your staff and provide quality care to your residents. We are grateful for your continued support, and we are here for you when you need our assistance and resources. It actually looks like we just had one question pop in, so I will go ahead and read that off real quick. Are you saying that we should apply to retain even if we're not able to get past the staffing question? Do we answer yes when we can staff and explain in the application that we are not able to staff and submit the application?
The first part of that question is yes. The department wants to know if you want to become a COVID relief facility. They kind of want to know that. They also want to know what the reasons are that you can't. So they do suggest if you're desiring that, but you can't meet the criteria, that you fill out the application. But when you get to the part where it says, can you meet the staffing requirements, you need to put no, because that's what they want to know. That is the expectation that they told me in terms of filling out the application for members who can't meet the criteria. To fill it out accurately, if you can't meet it, mark no, or whatever the right words are around that, and they will know what the problem is. I think that some of the flexibilities that we have seen come through in the last week about COVID relief facilities come from the fact that they can see that a lot of facilities are struggling with meeting all the guidelines. So I think this is one way that they get information about that.
All right, thank you, Deanna. And with that, I believe that will conclude today's webinar. So I hope everyone has a great remainder of their Friday, enjoys their weekend, and stay safe. Thank you.